So it's really great to be back and to see friendly faces in the audience. So first of all, it's a great honor for me. I spent 93 to 95. I took my epi lessons here, biostats. I slept through most of it, but I've come out on top, I think. So don't lose hope. All right. So after I finished my medical studies, I came to Yale 20 years ago. It was in 1993, August or September, that I came here to start my public health studies. At Yale, I learned that medicine had very little to do with health, and that it had everything to do with society, politics, economics, the law, the environment. Here I became concerned about the health of the disadvantaged, the neglected, the voiceless. It was here that I learned about the notions of equality and equity. Here that I came to believe that all human beings, no matter their race, creed, or beliefs, had the right to health care. Here I became a humanitarian, so thank you very much. The title of my talk may be a bit of a puzzle. Surely humanitarian medical action is all about danger, working in places where the risks are high. With the state of the world today, with the number of armed conflicts growing in recent years, it reached about 37 in 2011, though still not thankfully reaching the 50-something of the early 1990s. So just when I left college, that was about the time when we had the maximum number of active conflicts in the world. 92, 93, about 50 active conflicts. So surely the need for humanitarian medical action is greater than ever. How can it then be in danger? So I'll therefore just explain a bit what I mean of what humanitarian medical action is and of what Medecins Sans Frontières is all about. Then I'll talk about the dangers and show you what is happening in some of our programs at the moment we're talking about now, before closing with a brief overview of what is being done to address the dangers and what more can be done. Medical action is pretty self-explanatory. The humanitarian part may be pretty obvious, but increasingly, humanitarian is being used to describe all kinds of activities. So let me define it. Humanitarian action is about delivering assistance to people in crisis solely based on need. No political considerations, no religious considerations. It's solely based on need. The only prioritization made by humanitarian is that of need. Humanitarian action is in fact quite limited in its scope and in its objective. We do not seek economic development. We do not seek to restore human rights. We do not seek peace. We seek to assist the survival and alleviate the suffering of people in need in the here and now. So this is a key distinction between humanitarian work and development work. Humanitarian work is about alleviating suffering. Development work is about alleviating poverty. They're both very worthwhile enterprises, but they're very different in the way you approach it and the way you carry out activities. Humanitarianism is founded on principles of humanity, impartiality, neutrality, and independence. Without these, it is impossible to provide assistance according to need. We communicate with everyone, we depend on many others, but taking sides put the entire humanitarian project in danger. MSF, or Medecins Sans Frontières, is a humanitarian organization. We were founded over 40 years ago in Paris, France. A handful of French doctors had returned from the civil war in Nigeria. The Biafran crisis had lasted more than 2 years and taken more than 1 million lives. The doctors were frustrated by the Nigerian government's interference in aid efforts. They could not accept that health workers had been kept away from people in the most urgent need of medical care. They felt unable to remain silent and about the suffering that they saw and they had witnessed. These doctors and a group of journalists founded Medecins Sans Frontières in 1971, and the journalists had just returned from covering the 1970 the big cyclone. I forget, Cyclone Bola in Bangladesh. More than 500,000 people died in that cyclone in Bangladesh. So the journalists were very affected by that. The doctors had just come back from Nigeria, really wanting to do something different. They came together in 1971. MSF was created. MSF was to be an independent organization that would stop at nothing to offer life-saving medical and humanitarian relief quickly, effectively, and impartially. The first small groups of MSFers went to assist victims of natural disasters in Nicaragua and Honduras, and then Cambodians in Thailand who had fled the Khmer Rouge. I first became aware of MSF in the 80s while a medical student in India. I was awestruck by their exploits and their ability to deliver healthcare in extremely difficult settings. I decided that I wanted to join this band of doctors traveling the world and providing healthcare. I managed to get their address in Paris from the BBC World Service. Those days there were no internet, so you had to write to, there was the program. BBC had a program where listeners could write into, and they would then, try to honor your request. So they sent me the address of MSF. I wrote to them, but I never heard back. So this was in about 85. I was a medical student in India. In 1994, on my way back from a summer in South Africa, supported by a Downs Fellowship, I happened to meet a real-life MSFer at the airport in Brussels. We started talking, and before I knew it, he asked whether I would be interested in setting up a tuberculosis control project in Ethiopia, in Somali part of Ethiopia. Of course I was. But I had another year left at Yale, so I was a good student. I came back, and Professor Levin can attest to the fact whether I was a good student or not. But I came back, finished my courses and thesis as fast as I could, and then I was on my way. And that was April 1995, exactly 18 years ago, this week. That's when I left. And so it all worked really well. So, but I missed my graduation. So I wasn't here for my graduation. So, but here are some pictures. There's me at the graduation. There's Professor Levin. There's me again. And of course, the beautiful women. So it was. We had a wonderful group of students, and even though I was in Ethiopia in the middle of nowhere, one day I get a packet of photographs. It was just wonderful time I had here. Now, today, more than 30,000 MSFers are working in some 70 countries around the world. MSF doctors, nurses, surgeons, psychiatrists, logisticians, engineers, and support staff provide medical care to people caught up in conflict, affected by natural disasters or epidemics, or simply excluded from healthcare. 40 plus years since we were found, MSF's motivation remains the same. We cannot accept that people go without the medical care they need, desperately, be it by intention, neglect, or circumstances beyond their control. Our aim is to cut through issues of politics and money so that we can assist the survival of these people in crisis. Now, as a medical organization, we not only work according to humanitarian principles I mentioned of humanity, impartiality, independence, and neutrality, but also according to the principles of medical ethics, respect for autonomy, beneficence, non-maleficence, and justice. So in addition to treating patients, we speak out or bear witness to extreme need and unacceptable suffering. Which sort of brings me back to the danger part of my talk. Why is humanitarian medical action in danger? More than 8 million patients visited our hospitals and clinics last year. This is a huge number. But these 8 million people represent just a fraction of the number of people who need medical care. There are large numbers of people who do not. I mean, many millions of people who go without health care every year. Some 60% of MSF's programs are carried out in unstable contexts. Yet, in many of these contexts, we are unable to bring the kind of assistance we would like and we know that these people need. So in Syria, we have not been able to work in territory under government control. Despite our neutrality, we have been refused access. In Mali, we could not cross the front line during fighting and had to curtail our activities because insecurity forced us to restrict our movements. In Pakistan, the insecurity for our teams in some areas is such that we are unable to operate with our usual mixed teams of international and local staff. In Afghanistan, we have had to open programs slowly and cautiously and restricted our activities to urban areas. According to Aid Worker Security Database, 308 aid workers were killed, kidnapped, or wounded in 2011. Most incidents occurred in just a few countries: Afghanistan, Somalia, South Sudan, Pakistan, and Sudan. But then there are other figures. The International Committee of the Red Cross have statistics on attacks on health workers in 22 countries. They recorded 905 events in 2012. Now, I'm not necessarily vouching for these numbers or the methodology that came up with them, but they give an impression of the problem. In fact, we are now working really hard to figure out a way to record serious incidents and kidnapping, serious events that affect our ability to carry out our work, because it's important to get a real quantitative sense of the problem. In all of these countries and more, we know that our activities are severely limited. We're trying to reach as many as we can, but thousands of people remain unable to access the health care they need. These are the people I want to focus on today, the non-patients, because this is where the danger for humanitarian medical action lies. Respect for patients, medical staff, and facilities is paramount for impartial and unhindered access to quality health care. This respect is suffering everywhere. Even in Europe, in North America, we are seeing incidents of violence towards medical staff. Studies show that health workers are at increasing risk of violence at their workplace. Some studies say 6 times more risk than other service providers. The principles of the independence and neutrality of medical action are definitely under attack. There are perhaps different categories of attack. Violence against patients and staff is the most extreme, and then violence against facilities. An even lesser form of attack like obstruction, harassment, intimidation, the kinds of events that may not be reported, let alone acted upon, all contribute to an erosion of respect for the impartiality, neutrality, and independence of humanitarian medical action. It is notably our local staff, the people we hire locally in the countries where we work, who suffer most from threats and intimidation. The doctor, for example, whose life is threatened because she provides medical legal certificates for patients who've been raped, or the doctor who is forced to carry out a certain kind of medical treatment. The consequences go a long way beyond the immediate damage they do to people that are directly involved. The lack of respect for humanitarian medical action leads to long-term reduction or suspension of activities. It destroys trust and confidence in health services. It means thousands of people who need medical attention do not get it because they're too afraid to seek it or because it is not safe for medical staff to deliver it. And this is indeed the objective of the people who perpetrate such crimes. Today, I want to give you an idea of the scale of the problem and of the public health impact. I'm going to take you to some of the places we work and tell you about some of the incidents MSF staff have experienced over the past 18 months or so. They cover the whole range of attacks from direct violence against people to attacks on facilities and the obstruction they pose. Today is the 560th day that my colleagues Mone and Blanca remain captive in Somalia. They were abducted while working in one of the refugee camps in Dadaab, Kenya. We continue to work for their release. During their abduction, a Kenyan colleague was shot and seriously wounded. The consequences for the 475,000 refugees estimated to be living in Dadaab have been grave, because when our staff are not safe, it has implications on the services that we can provide. Following the attack, MSF evacuated part of its team who were working in 2 of the 3 refugee camps in Dadaab. MSF maintains life-saving activities, but other important medical activities were stopped. The insecurity in the camps caused many aid organizations to seriously scale back the assistance they were providing. So a clear example of how an attack can impact patients. At the end of 2011, 2 members of our coordination staff, a Belgian program manager and an Indonesian doctor, were killed in Mogadishu, Somalia. As a consequence, 2 separate 120-bed medical facilities treating patients for malnutrition and measles were closed. A cholera treatment center was handed over. These facilities served 200,000 people. We halved our medical assistance in Mogadishu. Attacks on health staff or facilities are often a sign of the intensification of hostilities, but they can also be part of military strategy from the outset. In Syria, early on in the conflict, doctors risked arrest and being labeled enemies of the regime for treating the injured. People injured in protests stopped going to public hospitals for fear of arrest. The provision of healthcare has been transformed into an act of resistance in Syria today. Air raids have targeted health centers. 57% of public hospitals have been damaged. More than 1/3 are no longer functioning. Makeshift and private facilities have not been added to this tally. Some communities are refusing the setup of medical facilities because of the fear that they will attract air raids. Now, this is a serious departure from Geneva Convention and other laws that we have in place which protect medical facilities from such attacks. MSF has so far been able to set up 3 field hospitals in opposition-held areas of Syria. So not in the areas controlled by the government, but in the opposition-controlled areas. But these are only able to handle a small fraction of the unmet medical needs in the country. MSF has been repeatedly refused access to government-controlled areas. I personally have been asking for a visa and a meeting with President Assad for the last 2 years, and we have been refused every single time. When clashes first erupted in northern Mali in early 2012, MSF began offering basic health services. These services were extended and expanded as fighting wore on. In 2013, conflict intensified further as Islamist groups reached central Mali, and French troops intervened in support of government forces. There were reports of injuries and deaths in the town of Konna, but MSF could not gain access. Our team's neutral medical personnel could not cross front lines. Elsewhere, nobody was moving. People could not get to health facilities. This was the case in Douentza in January, in Timbuktu in April. People were dying because they could not get medical treatment. The situation in Central African Republic has been similar. MSF has not been able to secure safe passage for patients referred for specialist care. Other activities were disrupted as the movement of health staff and the people in need of treatment were restricted. MSF health facilities have been looted in several locations and more than once prompting the evacuation of staff. This is all going on as we speak in Central African Republic. In Myanmar, a variety of problems have prevented MSF staff from accessing the sick and injured. Violence between the majority Buddhist Rakhine people and the Muslim minority known as the Rohingya in Rakhine State on the west coast of the country forced the team to suspend most activities in June last year. Then MSF staff were threatened. A small but vocal group within the Rakhine community have accused MSF of pro-Rohingya bias. Their intimidation has severely impacted medical activities. And this intimidation takes the form of putting pictures of doctors, nurses with their addresses on websites so that people can go and harass them, target them, etc. So these are really atrocious conditions to be working under. In Yemen, MSF supported surgical hospital in Aden, and that was closed last September after armed groups entered the hospital grounds and exchanged gunfire inside the hospital. 2 hospital guards were beaten and a third was threatened at gunpoint. There had been frequent security incidents in the hospital since MSF began activities. In April, doctors were seriously threatened by patients. In May, armed forces forcibly entered the building in an attempt to remove a patient. In July, shooting took place at the hospital gate. Nonetheless, the hospital had provided treatment for more than 500 patients between April and September. Now patients will have to go somewhere else, if there is somewhere else to go. The hospital director has stated that the situation has never been as bad. Healthcare is no longer respected for what it is, a basic need for everyone. In April 2012, exactly 12 months ago, 7 people were injured, including 1 child, by an explosion at our brand new maternity hospital in Khost in Afghanistan. This 56-bed hospital had opened just 6 weeks earlier, but had to be closed. We were only able to reopen in December. Given that in 6 weeks alone, 600 babies had been delivered, how many women were deprived of much-needed care during the months we were closed? In Pibor, I was here just a few weeks ago. In December 2011, in South Sudan, the MSF hospital in the town of Pibor was looted and ransacked. Our clinic in Lekwongole was burnt. The staff had to flee and hide in the bush. Hospital was left empty. The MSF facilities represented the only medical services for 160,000 people in Pibor County. It's one of the most remotest places on earth that I've been to. In 2011, the team carried out more than 35,000 consultations. The nearest alternative medical facilities are more than 100 kilometers away. But MSF facilities in Lekwongole and Gumruk were again seriously damaged in August and September 2012. Our staff ran a makeshift clinic in the bush, providing emergency care to the people who had fled the homes. These are medical teams who are fleeing with the people and still providing health care. In Sudan, government authorities have imposed more and more restrictions on our activities. Humanitarian organizations cannot access areas controlled by opposition groups in Darfur and in places where MSF is working. Deliveries are subjected to delays and obstruction. In DRC, our team suffered dozens of security incidents every year. Last month, shelling hit Sam Benoit Hospital in Kichanga, North Kivu. 2 people were killed and 8 wounded. In February, 2 MSF health centers in Katanga province were looted. The fighting also led to a drop in people visiting health facilities and curtailed MSF activities. 1 child, delayed by a roadblock, arrived too late at the MSF hospital and died of severe malaria. Last year, violence in Pinga, North Kivu, meant that majority of MSF's Congolese staff, along with the rest of the population, had to flee the town twice in 6 weeks. The health center and hospital kept going, but with a skeleton staff, could only provide limited services. Violence also prevented MSF teams from supporting surrounding health facilities. That's a long list. 12 months ago, armed uniformed men raided an MSF house in Baraka, South Kivu. 2 MSF colleagues were kidnapped near Nyanzale, North Kivu, and were thankfully released a few hours later. The persistent insecurity and conflict in eastern DRC is weakening the population. People cannot get to their fields to grow their food. They cannot access basic services. But the insecurity is also putting healthcare in danger. We have reduced or suspended activities and even withdrawn teams from certain areas. Thousands of medical consultations have not taken place and will not take place when they are most urgently needed. This list is just a snapshot of recent events in MSF's experience, and I restricted it to the last year. And we're talking 2012 and 2013. So, and it's just our experience as MSF. And I've not mentioned the use of health facilities to target protesters and the arrest of doctors in Bahrain, for example, in 2011, or the attack on a vaccination site in DRC in 2009, or soldiers' forced entry to a hospital in Haiti in 2006. It is safe to say that humanitarian medical action is in danger. And, I restricted the title to humanitarian medical action, but medical action in many places where we work is in danger. What can we do about it? What are we doing about it? First, we must, as health workers, uphold the moral principles of medical ethics under all circumstances. We ourselves are responsible for preventing the corruption of the medical act, because doctors are also part of society. They also have political agendas. They also have their own reasons for wanting to militate, etc. But we have to have some separation and protect the medical space in the countries where we work. At the beginning of this year, deans of public health schools from across the U.S. condemned the, and I quote, contamination of public health programs with covert activities. The dean's letter criticized the sham vaccination campaign allegedly carried out by the CIA in its attempt to gather intelligence on Osama bin Laden. Many of you probably have seen the movie. Such action, such recognition of the need for medical personnel themselves to work to safeguard medical ethics is vital. Doctors have to be a bit more careful before being co-opted into covert operations like these. Because the tragic death of workers supporting polio vaccination activities in Nigeria and Pakistan in recent months cannot be entirely unrelated to this incident. We're talking about more than close to 20 people dead after after it came out that the CIA had carried out this vaccination campaign just to locate Osama bin Laden. Second, we must continue to stress the importance of humanitarian principles and the true meaning of humanitarian medical action: humanity, impartiality, neutrality, and independence. Third, we must keep talking with all communities, authorities, and leaders. We must keep up communications with all parties to secure and maintain their acceptance of our work in sensitive contexts. The space for humanitarian medical action is not fixed, and it's not a given. It must be created. We can only work with the acceptance of all parties. That means in Afghanistan, we have to talk to the Afghan government, we have to talk to the US soldiers, but we also have to talk to the Taliban. Fourth, as part of this communication, we must stress the principle of reciprocity. We must stress that if one belligerent wants to benefit from medical services for themselves and the people in their territory, then they must respect the desire of other warring parties for the same. Healthcare benefits everyone, and it is in the mutual interest of everyone to preserve it. And finally, we can make clear globally the medical consequences of attacks on patients, health workers, and health facilities. The Red Cross has launched a campaign, Healthcare in Danger, to raise the awareness of the problem and to quote them, halt violence against healthcare before it occurs. This year, MSF has begun a 3-year research project that will collect data on violent incidents. Starting with 10 pilot countries, the project team will collect the data to analyze the impact of the incidents and our response. With this evidence base, the objective is to determine what activities, both locally and globally, will improve safe access to and delivery of healthcare. Because, let me return to the beginning, humanitarian medical action is in danger. People in DRC, Syria, Pakistan, and elsewhere are all being denied healthcare because of the lack of respect for humanitarian medical action. We clearly need to act. Everyone in need of healthcare must have the adequate and unhindered access to health services. Health workers must be able to assess and provide for those that need impartial and effective medical care. Thank you.